Hello everyone, very good evening to each one of you. Please let me know whether I'm clearly visible and audible so that we can proceed with the session. Hi guys, so finally it's working. There was some technical issues. Hi, it's been a long time. We are meeting at Meduhub now, and we are coming up with a very new plan. And I know exam is approaching soon. You are not having a lot of days in your hand, so we are coming up with a solution. We are having the live classes. We are having rapid revision classes for the next 60 days for upcoming examination. So you can, yes, you can join the Meduhub application for that particular thing. Yes, we are going to have a rapid review of diabetes mellitus today. We are going to learn what is diabetes and how it is going to happen, what is the pathogenesis, what are the different things. We are going to learn about the physiology, what are the aspects that you should be knowing about the pharmacology and all, right? So we are going to start it off with the diabetes. Working now. Okay, so please give me a quick confirmation so that we can proceed with the session. All right, so today we are going to learn about diabetes. What is diabetes, how it is going to happen, and definitely you will be getting some questions in each and every examination, whether it is INI set, whether it is NEET PG or FMGE, every exam. Definitely there will be a question from diabetes, there will be questions from thyroid. So we are going to learn about that, right? So we are beginning with the first thing. You already know that pancreas is a gland which is going to have two important parts, right? Pancreas will be a endocrine gland as well as exocrine gland, right? So we are going to learn in the format of a story. Once you understand the basic physiology around it, it will be very easy for you to understand the diseases, what is going to happen in diabetes, right? It is very simple. Just try to be with me till the end of the session. So we are going to learn about the pancreas. Pancreas will be having how many cells? Pancreas will be having alpha cells, beta cells, and delta cells. Importantly, alpha cells will be releasing what? Try to answer whatever you know. Alpha cells will be releasing what? Glucagon, right? Beta cells will be releasing what? Insulin. And delta cells will be releasing what? Somatostatin. Right? Alpha, beta and delta cells will be there, right? Alpha cells will be releasing glucagon, and this glucagon is responsible for glycogenolysis. It is going to do what? Glycogenolysis. Glycogen is what? Glycogen is the storage form of glucose, right? It is the storage form of glucose. Whenever your body will be having low glucose, what will happen? This glucagon is going to come into action, and this glucagon is going to do what? Glycogenolysis, leading to increase in the blood sugar level. It is going to increase your blood sugar levels, right? It is going to increase your blood sugar levels. What about this beta cells? Beta cells will be releasing what? Insulin. And this insulin, remember, this is going to do what? Glycogenesis. Very important question from the biochemistry. It is going to do what? Glycogenesis. And it is going to decrease what? It is going to decrease the blood sugar levels. Right? And what about the somatostatin? We have already discussed somatostatin is a universal inhibitor. Whenever you have this word somatostatin, it is going to do what? Inhibition. So it is going to be a universal inhibitor. You can remember like that. So what it is going to do? It is going to inhibit your alpha cells. It is going to inhibit your beta cells also, right? So suppose if you have a cancer of glucagon cells, like you are having glucagonoma, so what we can use? We can use somatostatin because it is going to inhibit what? Alpha cells. It can also be used in the cases of insulinoma also. And what is the drug that is going to be a somatostatin analog? That is going to be your octreotide, right? So this octreotide can be used in the insulinoma as well as in your glucagonoma, right? Apart from that, let's try to understand what are the food we are eating and how it is going to get digested. What is the function of this particular system, right? So we are having this alimentary canal. Alimentary canal means opening of mouth till ending of the anus, right? What is the function of GIT? What is the function of GIT? Function of GIT is what? Assimilation. If our basics are clear, it will be very easy, right? Assimilation will be comprising of two important steps. First one is going to be digestion. So whatever things you are eating, that will be digested, and second function of this GIT is going to be absorption, right? What are the things you are eating? You are eating carbohydrates, you are eating fats, you are eating carbohydrates, fats, and proteins, right? Apart from that, vitamins will be there and minerals will be there. So these are the only 5 things that you are eating, right? Macro and micronutrients, right? What is the function of this digestion? Digestion ka function kya hota hai? What is the meaning of digestion? Digestion means to break down complex carbohydrate that you are eating into simple glucose molecules. Suppose you are eating roti, suppose you are eating dosa, whatever things, momos you are eating, ultimately it is going to convert into what? Suppose you are eating momos, it will be converting into glucose. This is the process. This is known as this is the first process of digestion. Digestion will be having 2 things. The function of digestion is what? To break down complex carbohydrate into simple substances. So what is the basic function of this GIT? Complex substances will be converted into simple absorbable forms, right? And then you will be having the absorption. We are having blood transporter for glucose, we are having SGLT for glucose, right? This is what we are going to discuss over here, right? So suppose you are eating momos. Now let's try to understand what will happen with those momos, right? Whatever momos you are eating, it will be going to your mouth, then your esophagus, then your stomach, then your intestine. What are the parts of intestine? You are having small intestine, duodenum, jejunum, ileum. Then you will be having large intestine, you will be having cecum, ascending colon, transverse colon, descending colon, sigmoid colon, and then rectum, right? So this is going to be the basic pathway for the food, right? Whatever you are eating, whatever things you are eating, it will be directly coming out through your anus. This is alimentary canal. The function of alimentary canal is to do digestion and absorption. Whatever food you are eating, it will be having carbohydrate. That carbohydrate will be converted into glucose, and this glucose is going to get absorbed with the help of SGLT and blood pumps. This is the basic functioning. Whenever this glucose from your mouth is going to come into blood, whenever this glucose is going from your mouth, from your alimentary canal, it is going to come into absorption of come into blood. After the absorption, this is going to be what? If you are having more glucose in blood, if you are having more glucose in blood, what do we call it? More glucose in blood, that is known as hyperglycemia. That is known as hyperglycemia. So what is going to happen? Whatever extra glucose that you are eating, it will be going into your mouth, it will be going into your duodenum, jejunum, ileum, and then you will be having digestion of those complex carbohydrate. It will be converted into glucose, and now this glucose can get absorbed into the blood vessel, right? What are the layers do we have in our GIT? We are having 4 layers. The innermost layer, that is going to be the mucosa. Then you are having what? So we are having the innermost layer, that is going to be mucosa. Then we are having submucosa. Then we are having muscularis. And lastly, we are having serosa, right? So whatever food you are putting, it will be, it is like a pipeline, right? So what is going to happen? The food will be inside of which cavity? The food will be here. The food will be here, and this food will come in contact with the mucosa. Here you will be having villi, microvilli will be there, and submucosa. Remember, this submucosa will be having what? Blood vessels, right? This submucosa will be having glands, it will be having blood vessels. So when this food is getting digested, after conversion of this food from complex carbohydrate to simple carbohydrate like glucose, what is going to happen? This glucose is going to come into the submucosa. When this glucose is going to come into submucosa, what will happen? The submucosa will be having high level of glucose. This submucosa will be having high level of glucose, and this glucose will be more in the blood, and this particular thing is known as hyperglycemia. This particular thing is known as hyperglycemia. So whatever food we are eating, it is going to do what? Hyperglycemia. Now let's try to understand. When you are having more glucose in the blood vessel, this is known as hyperglycemia. This is known as hyperglycemia. And you already know blood is a connective tissue. Blood is a connective tissue. So what is the function of a connective tissue? Connective tissue means what? It will be transporting things all around the body, right? Now this glucose will be transported all around the body through the blood. Blood is a connective tissue, right? So what is going to happen? This glucose is going to come, and this glucose is going to come near these cells. What are these cells we are having? This is, suppose this is a blood vessel. It will be having hyperglycemia, and here you will be having these cells. These cells are known as beta cells. And remember, we have discussed just now, beta cells are going to be present where? Beta cells are going to be present where? In the pancreas, and the function of beta cells is to release what? Insulin. Now let's try to understand how this insulin is going to come. First thing we are having, after eating of the food, sir, we are having hyperglycemia. Now I'm going to make you understand how this hyperglycemia will be controlled with the help of insulin, right? So it is going to be just like a story. Just try to understand this. So you will be having this high glucose in the blood vessel. What is going to happen? This beta cells will be having a special transporter. This is known as GLUT, glucose like uptake transporter. This will be having GLUT. Which GLUT will be there? Very important question. It will be having GLUT2. And now what is going to happen? This GLUT is a type of facilitated diffusion. Question from physiology, previous year question, I'm going to mark, right? So this is a GLUT2. GLUT2 is a type of facilitated diffusion. Facilitated diffusion means it does not require energy. It is a type of passive transport. So it does not require energy. Now what is going to happen? This glucose is going to come inside this glucose is going to come inside. Let me make a small glucose for you. Now what is going to happen? This glucose is going to come inside this beta cells. When this glucose is going to come inside this beta cells, what will happen with the glucose? We already know glucose will be having what? Glucose will be having glycolysis. Glycolysis, biochemistry link, right? Glycolysis, how many ATPs are formed in the glycolysis? Try to answer. How many ATPs are formed? Remember, 7 ATPs are formed, right? Whenever this glucose will be coming inside, you will be having formation of this pyruvic acid. This is known as glycolysis. After glycolysis, end product will be pyruvate, and this pyruvate formation will lead to formation of some ATPs. How many ATPs will be there? 7 ATPs will be there. Now what this ATP is going to do, remember, this ATP is going to block a channel, because this is a ATP sensitive potassium channel. Here you will be having a channel. Look here. Here you will be having a channel, and this channel is going to be ATP sensitive potassium channel. That means whenever you have the ATP, what will happen? This channel will be closed. If this channel will be closed, earlier there was potassium leaking out through this channel. When you close this channel, what will happen? This potassium will get accumulated inside. If a positive charge is accumulated inside a cell, we call this type of cells as a depolarized cells, right? So what is going to happen? As soon as this potassium channel is blocked, what will happen? This potassium will be staying inside, right? And this cell will be depolarized, and because of depolarization, what will happen? This calcium channel will open. All these things are very important. Once you understand this, it will be very easy for you, right? So what is going to happen? Because of depolarization, calcium will come inside, and I'm telling you 3 things about calcium that you need to remember throughout your life. Calcium in the muscle, it is going to do what? In the muscle, this calcium is always going to do what? In the muscle, it is always going to do what? Contraction. In the vessel, it is going to do what? Vasoconstriction. And in the cells, whenever any cell will be having entry of calcium, it will do a thing. This is known as exocytosis. Exocytosis means something will be coming out, something will be going out. So what will happen? As soon as this calcium will come inside, what will happen? This insulin vesicle was there. Insulin vesicle will be coming out, and now this insulin will be coming where? This insulin will be coming into the blood vessel. Now this insulin will be coming into the blood vessel. Why in the blood vessel? Because insulin is a endocrine gland. Pancreas is an endocrine gland, right? It is a part of endocrine gland, and insulin is a hormone. And remember, all the hormones will be directly poured into the blood, right? So what is going to happen? Suppose this is your insulin. Now you are having these insulin molecules in the blood. Earlier you are having what? Hyperglycemia. Now you have what? Now you have insulin in the blood. Now what is going to happen, just try to understand. This is a connective tissue, right? Yes, blood is a connective tissue. So what is going to happen, look here, this blood will be traveling all around the body, different cells of your body, right? We will be having some specific cells. What are the names of these cells? Let's try to understand this. So we are having some specific cells, like we are having cardiac muscles, we are having cardiac muscles, we are having skeletal muscle, we are having skeletal muscles, we are having adipocytes, we are having adipocytes. So now what is going to happen, this glucose was there in the blood, and now this vessel will go along this particular cells, and these are the cells: cardiac muscle, smooth muscles, your not smooth, skeletal muscle, and your adipocytes will be having a special transporter, and the name of this transporter is going to be what? GLUT4. Here you will be having GLUT4, and remember, this GLUT4 is closed. This GLUT4 is closed. Now what will happen, as soon as this insulin, this is your insulin is the key from now onwards. Insulin is what? Insulin is the key. Now this key will come. Now this key will come, and this key will come and it will bind here. As soon as this key will come and bind here, what is going to happen? There will be some gates which are going to get opened, right? And now what will happen? This extra glucose which was there in the blood, now this extra glucose which was there in the blood, now it can enter into the cardiac muscles, now it can enter into the skeletal muscles, right? Now this thing can get entered, right? So you understand now what will happen. Now you will be having decrease in the levels of glucose in the blood, and this particular thing is known as normoglycemia. Normoglycemia means glyce means glucose, normo means normal, emia means in the blood. So now you will be having normal glucose levels in the blood, right? So this is the basic understanding that you should be having. Let's try to I'll just try to recap it for you. What is going to happen? Whatever food we are eating, it will be going into your stomach. In the stomach you will be having digestion. In the complete alimentary canal you can have digestion, right? Digestion you will be studying in physio, right? So you will be having those digestion. After digestion, what is going to happen? You will be having conversion of those big molecules, complex carbohydrate, into the glucose, and now this glucose get absorbed into the blood, and this absorption is going to be known as what? Now you have the glucose in the blood. This is known as hyperglycemia. As soon as you have the hyperglycemia, blood is a connective tissue. This glucose will travel all around the body. It will go to your pancreas also. In pancreas you will be having which cells? You will be having beta cells, and beta cells will be having GLUT2, and now this glucose can enter into GLUT2 cells, right? Now this with the help of this GLUT2, this glucose can enter into beta cells, and now this beta cells can do what? Here you will be having first thing, that is going to be glycolysis. You can also have Krebs cycle after this. After glycolysis there will be Krebs cycle, right? Ultimately there will be formation of ATPs, and here you will be having ATP sensitive potassium channel which is going to get closed after this ATP formation. Why this is important? Because you are going to use a lot of drugs. Definitely there will be questions from the drugs like sulfonylureas. You study glimepiride, gliclazide. All these drugs are going to block this pump directly, right? So what is going to happen? You will be having ATP formation. First understand the physiology, right? What is going to happen? This ATP is going to block this channel, and because of that now potassium cannot leak out. This potassium will get accumulated inside. Once this potassium can get accumulated inside, you will be having depolarization. Accumulation of positive charge is known as depolarization, right? So what is going to happen? Because of this depolarization, calcium will come inside, and because of entry of calcium, three functions of calcium, one function is going to be exocytosis. So as soon as calcium will come inside, this insulin vesicle will be released outside, right? It outside where? Into the blood. So now you have what? Now you have the insulin into the blood. And what is the insulin from now onwards, beta? Insulin is going to be the key. Insulin क्या है? Insulin चाबी है. किसकी चाबी है? इस ताले की. कौन से ताले की? Which is the lock we are having? The lock we are having, that is going to be the GLUT4. So this GLUT4 will not get opened. These pumps will not get opened if you do not have this key. Without key you cannot open the door, right? So what is going to happen? You cannot open this, right? Once you have this insulin, now this insulin will come and this insulin will bind, and now you have all the glucose will go inside. Cardiac muscles are going to use, what is the source of energy in the cardiac muscles? This is your biochem question again. So remember, heart muscles or cardiac muscles are going to use what? What is the primary source of energy? Cardiac muscle, the primary source of energy is going to be fatty acid. And what is fatty acid? Long chain of triglyceride. This is going to be what? Triglyceride. It is going to become what? Triglyceride. So long chain of triglyceride is known as fatty acid, and this is the fatty acid which is going to be responsible for what? For the cardiac activity. Apart from the cardiac activity, you will be having what? You will be having skeletal muscles. You will be having skeletal muscles, and in skeletal muscle, whatever glucose you are going to give, this glucose will be doing what will happen with the glucose in skeletal muscle? You will be having glycolysis. Then you can also have TCA cycle or Krebs cycle, and ultimately this TCA cycle will lead to this TCA cycle will send the electrons, it will send the energy to electron transport chain. You will be having, after ATC, what is going to be happening with the glucose? This glucose will convert into H2O plus CO2 plus energy plus ATP, right? This is what is going to happen in your body normally. Whatever food we are eating, this food will be making glucose. This glucose will go to skeletal muscle. I am doing some kind of running exercises. What is going to happen? You will be having glycolysis of that glucose. You will be having TCA. This glucose after glycolysis, this particular thing will go to TCA or Krebs cycle, and then it will go to ETC, and ultimately you will be having what? Formation of H2 and CO2. So this glucose, whatever food we are eating, is going to convert into H2O and CO2, and you will also get what? ATPs, right? And if you are eating more, this is what is suffice for your energy. If you are eating enough amount of food, that is going to be good thing, right? But if you are eating more, just try to understand one more concept over here. What is going to happen? This is going to become what? Adipocyte. This is going to become what? Fat cells. What is basically fat cells? Fat cells are going to be nothing, but this is going to be long chain of triglyceride is going to become what? Long chain of triglyceride is going to become what? Fatty acid. And when this fatty acid is going to bind with the alcohol, this is going to become what? Lipid. This is going to become what? Lipid. And this lipid can get absorbed in your body, it can get digested in your body, it can get stored in your body, right? So you can have this formation of the lipid storage will be there. Basically, whatever extra food you are eating, it is going to convert into adipocytes, right? So extra glucose that you are eating, extra momos that you are eating, it is going to convert into adipocytes, and you will be getting fatter, right? You understand this basic functioning. Once you understand this basic functioning, you will be having what? You will be understanding all the diseases very nicely, right? So what is going to happen? No issues with this. Give me a quick confirmation. All right. Okay, so what are the things which are going to happen? I've just tried to recap it in single diagram. We are having this pancreas. This pancreas will be having these islet cells, and this islet cells will be having beta cells, right? And this beta cells will be having what? Entry of glucose. As soon as you have entry of glucose, you will be making what? ATPs. Now this ATPs will block what? This ATPs are going to block this potassium channel. Potassium will not go out. So what will happen? Calcium channel will open. Calcium will come inside, and now this calcium will lead to release of this insulin into the blood. And now this insulin is going to be present in the blood vessel. What are the functions of insulin? Let's try to understand. In the muscle, what it is going to do? In the muscle, it is going to do what? Glycolysis. This is what we have seen. In the muscle, it is going to do what? Skeletal muscle, it is going to do glycolysis for the energy production. And second thing, it will also increase the glycogen synthesis. Whatever extra energy you are having, it will be stored in the form of glycogen. In adipose tissue, what is going to happen? It is going to do what? Increase in the lipogenesis. Lipogenesis means fat production. You will be having extra fat production. Lipolysis will be decreased. And you will be getting fatter, right? Next thing, in the liver, it is going to decrease gluconeogenesis. It is going to decrease your glycogenolysis. Gluconeogenesis. Gluco means glucose, neo means new, and genesis means formation. So new glucose will be formed from non-carbohydrate source, like your proteins will be involved here, right? Amino acids will be involved here. So this process will be decreased, and ultimately when you eat good food, when you eat more food, what will happen? You will be having increase in the glycogen synthesis. In the intestine, it is going to decrease what? Lipoprotein and glucose production. And in the brain, you will be having what? You will be having those satiety centers will get activated, and you will be having decrease in the food intake. And second thing, you will be having upregulation of mood, cognition, and neuroprotection, right? So mood will be elevated, because remember one more thing: whenever you eat good food, all the amino acid will go inside. The only amino acid that will come more into the blood is going to be what? This is going to be your serotonin. This is going to be your serotonin. And you already know serotonin is an amino acid which is going to be making you feel happy, isn't it? It is going to make you feel happy. Like most of the drugs we are giving, antidepressant. What are those antidepressant drugs will be having? Those antidepressant drugs will be like SSRI, we are having selective serotonin reuptake inhibitors. So we are having SNRI, right? Basically we are increasing what? Serotonin, and serotonin is going to make you feel happy, right? So that is what is a correlation that you can understand. Whenever you eat food, what will happen? You will be feeling happy. You will be feeling happy. Some people are going outside eating good food and they will feel happy about it, right? So this is going to be the thing about it, right? Now, the next thing we are going to understand is the different types of diabetes. If you understand this particular thing, now we can easily understand the different types of diabetes. How many types of diabetes do we have, and what are the basic pathogenesis behind this, right? So first of all, we are having type 1 diabetes. Type 1 diabetes. So what is going to be the major problem in type 1 diabetes? You can write one like this also, right? Or you can make one like this, right? So this is going to be the problem with the insulin. Here you will be having problem with what? Problem with insulin, or simply you can say, sir, problem with the key. If you do not have the key, let's try to understand. If you do not have this key, are you going to open this pump? Are you going to open these channels, Clutford? Yes or no? You cannot open these channels. If you cannot open these particular channels, what is going to happen? You will be having what? Hyperglycemia. This glucose will not go inside. This glucose will not get utilized, right? Till the time you will be having more glucose in the blood. जब तक blood के अंदर ज़्यादा glucose रहेगा, glucose is like a single molecule. जहाँ भी ये ग्लूकोज जाएगा ब्लड में, जब भी ग्लूकोज रहेगा, it is going to cause destructions, right? So it is going to go to your nerves, it is going to cause neuropathy, it is going to go to your eyes, it is going to cause retinopathy. So what is the ultimate mechanism? Whatever drugs I am going to teach you, 8 classes of drugs we are having, सारी दवाइयाँ क्या करेगी? All the drugs will try to decrease blood glucose. The ultimate purpose and the ultimate problem we are having in diabetes is what? Increased blood glucose, and this glucose is bad for us, right? So we just want to decrease this blood glucose. This is the only thing we are going to do in the diabetes. Diabetes is very simple once you understand the basic physiology around it, right? So what is the basic physio around it? This glucose will be going inside with the help of this key, right? What is the key? The key is insulin. The key is insulin. So what is type 1 diabetes? Type 1 diabetes will be having problem with the insulin. So there will be no key, and this is generally seen in the young patient. This is generally seen in the young patients will be there. Young age patients will be there, like less than 25 years of age, right? This is going to be these are going to be the people who are going to have this particular thing. Why this thing is going to happen? Just try to understand this. Here you will be having destruction of beta cells. Here you will be having destruction of beta cells. Approximately 80 to 90% of the beta cells will be destroyed. So if there are no beta cells, what is going to happen? How you are going to make insulin? If you are not going to make insulin, so what is going to happen? You are not going to open the log. You will be continuously having what? Hyperglycemia. Second thing, this is going to be an autoimmune disorder. The question they are asking, what are the antibodies we are going to have? So remember, here you will be having anti-isolate cell antibody. We can have anti-GAD. We can have anti-GAD 65 antibodies. It is also going to have certain association. This diabetes is also going to be associated with HLA DQ2, HLA DR3 and DR4. This is going to be the association with the HLA also. You can also have this particular disease after a viral infection, and the name of the viral infection post-viral, like we are having streptococcus infection that can cause what? Acute rheumatic fever, molecular mimicry will be there. Same story will also happen here in the Coxsackie B virus. Coxsackie virus. Here also you can have the diabetes. It has the strong association with diabetes. You have the Coxsackie virus infection, you will be making antibodies, and now these antibodies are going to these antibodies are going to attack your own beta cells, right? And this is going to be one of the important cause. What is going to be the treatment in this particular case? First problem, what is the problem? We do not have key. If we do not have key, how you are going to treat this particular situation? You are going to give key from outside, and that is going to be the insulin is going to be the drug of choice. Remember, insulin is going to be the drug of choice in this particular case. You can also use one more drug here, amylin analogs. You can also use amylin agonist, right? These are the only two drugs which are going to be useful in the cases of type 1 diabetes. One you can remember, it is also known as insulin dependent diabetes mellitus, because it is all about the insulin. It is all about the key. Now, what is the second problem we are having? The second problem we are having, beta, is going to be what? Type 2 diabetes mellitus, right? And can you make a R of 2? Can you make a R of 2? Just make a straight line and it will become R. R means what? It is going to be the resistant type of diabetes. Here you will be having the key, yes or no? Do you have the key here? Tell me, do you have the key here? What is the key? Key is the insulin, right? So do you have the key? Yes, we have the key. But now this lock is jammed. Which lock is jammed here? This lock is jammed. You are not going to open this lock. Key is also there, but sir, there is some problem with the lock. ताला जाम हो गया, क्या करोगे? ताला जाम हो गया तो क्या करोगे? How you are going to open it? If this lock isn't working, what you are going to do? You are going to put what? If your lock is not working, what you are going to do? And this is a disease which is generally seen in the old age, like more than 45 years of people, like adult people, will be having this particular disease. This is a multifactorial, or you can also call it like polygenic. Multifactorials will be there, like polygenic means multiple causes will be there, right? Here you can have positive family history. Positive family history can be positive, like mother is having the diabetes or father is having the diabetes. There is a chance the family will be having the diabetes, right? You can have this history association with the people are smoking nowadays, like obesity is a risk factor. So it is going to be a multifactorial disease. Some people are drinking alcohol, right? These are the factors which are going to increase the risk of this particular type of diabetes, and it is very common nowadays. So what is going to be the drug of choice if you are having this type of problem? If lock is there, key is there, but this key is not going to open the lock, क्या करोगे? Oil डालोगे, right? What you are going to put? You are going to put the oil. And what is going to be the oil here? The drug of choice is going to be what? Metformin. Drug of choice is going to be what? Metformin in this particular case, right? Apart from that, we are also having LADA. LADA is also known as diabetes mellitus 1.5. This is also known as 1.5 diabetes mellitus. This is going to be what? This is latent autoimmune diabetes in adults. So this is going to be a latent autoimmune diabetes in adults. Basically, it is a variant of type 2 diabetes. It is a variant of type 2 diabetes mellitus. But this particular entity is seen around the age of 25 years. Here also you will be having what? Autoimmune is there. Here also you will be having what? Antibody production. And what are the antibodies? This is the important question. Here you will be having anti-GAD antibody. Anti-GAD antibodies are going to be responsible here, right? This is going to be the LADA. Apart from LADA, we are having what? MODI. What is MODI? Maturity, onset, diabetes in young people. Maturity, onset, diabetes in young people. It will be having 6 types will be there. But for us, the most important thing that we are having is going to be the type 3. It is a autosomal dominant condition, means if the grandfather is having the same disease, if the grandfather is having this MODI, what is going to happen? This MODI is going to travel to the father also, and from the father this particular thing is going to travel to the son also. So there will be a high risk in the family, right? So you will be having this autosomal dominant type of inheritance that is going to be seen here. But this is not going to be a polygenic, like you do not have multiple factors around it. You will be having a single factor, and this is going to be a monogenic thing. The most common type that we are going to discuss is going to be the type 3 MODI. Type 3 MODI, and that is the most important that you have to remember. What is the gene which is going to be involved over here? This is going to be the gene which is going to be involved here is going to be HNF1 alpha gene. The gene which is involved here is going to be HNF1 alpha gene. What it is going to do? This gene is going to decrease the glucose entry into the cells, glucose entry into beta cells. So just try to understand now, if glucose entry is decreased in the beta cell, do you think there will be glycolysis? If there will be no glycolysis, there will be no ATP formation. If there will be no ATP formation, do you think this potassium channel is going to get closed? Do you think this channel is going to get closed? No. If this channel is not getting closed, no calcium will come inside, no insulin will go outside. Simple story, right? So what is going to happen? Here you will be having decrease in the glucose entry into the beta cell. Glucose entry is restricted. And what is going to be the treatment or drug of choice here? Here you will like to give sulfonylureas. Sulfonylureas are what? Sulfonylureas are the drugs which are going to work where? On the ATP sensitive potassium channel. It is going to inhibit the ATP sensitive potassium channel. So just try to understand, when you give sulfonylureas, what are the sulfonylureas? Those drugs which are having G plus ide. G means they are going to start with the G and they are going to end with the ide. So we are having drugs like glimepiride, gliclazide, gliblanclamide. All these drugs are going to come under what? These are your sulfonylureas. Let's try to understand what this sulfonylureas are going to do. So what is going to happen? These are going to block this particular channel. Sulfonylureas will work here. Now what will happen? The potassium will get accumulated automatically. If you are going to block this channel, potassium will get accumulated. Once potassium will get accumulated, calcium will come inside, and this calcium is going to be responsible for the release of insulin. Right? And once this insulin will come into the blood, now this glucose can easily enter into the cells like adipocyte, skeletal muscle or cardiac muscle. So this is going to be the basic understanding, right? That is why the drug of choice in this particular thing is going to be what? Sulfonylureas. Here you will be using what? Sulfonylureas as the drug of choice, right? Next thing we are having is what? Bronze diabetes. Next thing we are having is what? Bronze diabetes. Next thing we are having is bronze diabetes, right? What is going to happen in the bronze diabetes? Let's try to understand this. In bronze diabetes, we are having what? This is also known as hemochromatosis. This is also known as hemochromatosis. It is going to cause a disease that is known as hemochromatosis. I'll teach you the mode of action of all the drugs. Okay. Hemochromatosis. We are going to learn the management in the last after diagnosis, right? So bronze diabetes, also known as hemochromatosis, where you will be having some mutations in the break, like HFE gene mutation can be there. HFE gene mutation. And what is going to happen if you have this mutation? This HFE gene is going to make what? Hepcidin, and hepcidin is the brake, right? Hepcidin is the brake. Hepcidin is the brake for iron. Now this gene is mutated, so what is going to happen? Now excess of iron will come into your body. If your body is absorbing excess of iron, this iron will be present in the blood, and now this blood is a connective tissue. This iron will be transported all around the body. This iron will go to your liver, right? If it go here, you will be having what? Iron overload will be there. And if it will go to your skin, let's say if it goes to your skin, you will be having what? Hyperpigmentation will be there. Hyperpigmentation will be there. This hyperpigmentation is due to increase in melanogenesis or melanin synthesis. It will increase the melanin synthesis. You will be having hyperpigmentation on the skin. This particular iron will go to your islet of beta cells, and it will be doing what? It will do beta cell destructions. Once it will do beta cell destruction, you will be having symptoms of diabetes. So you will be having symptoms of diabetes. That is why it is also known as bronze diabetes. It will go to your liver. It will get accumulated in the liver, and it will cause what? Liver cirrhosis also. You can also have liver cirrhosis symptoms will be there, and you can have the disease liver cirrhosis because of this iron overload, right? So iron overload is very, very important, right? Apart from this bronze diabetes, we can also have type 3 diabetes. Type 3 diabetes is nothing, just a term that you need to remember whenever the patient is having Alzheimer. And along with the Alzheimer, if the patient is having diabetes like symptoms, classical symptoms of diabetes, okay, this is going to be what? Classical symptoms of diabetes are present. This is going to be the type 3 diabetes. Type 3 diabetes. So how many types of diabetes we have seen? What is the basic understanding about diabetes? Because if beta cells are not there, there will be no insulin. If there is no insulin, that glucose cannot go inside the cardiac or skeletal muscle. Second problem we are having is what? Second problem, we are having the key. We are having the key, but this key is not opening the lock. Sometimes we can have this lock jam situation, right? So this is going to be the type 2 diabetes. 2, you can make it like a R, and that is going to be the resistant type of diabetes. It is going to be multifactorial. Patient is thick, patient is having family history, patient is having bad habits, patient is obese, right? All these symptoms can be there, right? LADA, you will be having latent autoimmune diabetes in adults, and this is going to be due to antibodies, right? This is going to be due to antibodies. And what about this MODY? This is going to be maturity onset diabetes in young, right? This is going to be the MODY. And bronze diabetes, you understand, we are having type 3 diabetes. We can also have GDM. We can also have gestational diabetes mellitus. So GDM, you will be having GDM. What is going to happen? Due to, around the time of pregnancy, mother is having the diabetes, right? Because of the pregnancy, mother is having the diabetes. This is known as gestational diabetes mellitus. If mother is having the diabetes, what will happen? This increased levels of glucose will go to baby also, right? And baby will be having overproduction of what? Baby will be having liver. Baby will be having pancreas, and baby will be having functional pancreas. Beta cells will be there, and those beta cells will be releasing what? Increased levels of insulin. And if the mother will be having increased levels of glucose, what will happen? This glucose will be going to the baby. This baby will become big, and this baby is known as large for gestational age baby, or this is also known as macrosomia baby. So macrosomia can be there. This baby will be a big baby, right? Apart from that, his beta cells are working, and here you will be having more of insulin because beta cells are working for more glucose. Now what is going to happen? This baby, when this baby is going to come out after the delivery, this beta cells will be working nicely, right? And this baby will not get enough glucose, so this baby can end up into hypoglycemia also. That is what you need to remember. What is the complication of this GDM that you need to remember? This complication is going to be hypoglycemia in baby. After the delivery, this baby will be having more insulin because beta cells were working very nicely earlier. Now this baby is coming out, beta cells are still working, insulin is still working, but this baby is not going to get enough glucose after the delivery, right? After the delivery, he will be only drinking milk from the mother. Maybe it is coming, maybe it is not coming. He is not taking any other kind of glucose, right? So this baby might land up into hypoglycemia. This baby will sleep, and when he will open the eyes, he will be again in the heaven, right? So this thing can also happen. You need to understand about this, right? I was talking about the classical symptoms. So what are the classical symptoms of diabetes? Anyone? What are the classical symptoms of diabetes? Classical symptoms of diabetes are going to be what? Polyphagia. That means patient zyada khayega, right? Patient is going to eat a lot of things because it is going to activate your satiety center. It is going to activate your satiety center will be activated. Here you will be having polyuria will be there. What is polyuria? Polyuria will be there. Polyuria means what is the cutoff value? What is the cutoff value? This patient will be urinating. If the patient is urinating more than 3 liters of urine per day, this is considered as polyuria. Normal urine output is 1.5 to 2 liter. If someone is having more increase in the urine output, this is known as polyuria, right? What is polydipsia? Here also you will be having polydipsia. Polydipsia is going to be if someone is drinking more than 6 liters of water per day. This is going to be what? Polydipsia. This is going to be polydipsia. Why this polyuria is happening and why this polydipsia is happening? Let's try to understand this. Everything will be clear here. Look here, what is going to happen when you have more glucose in the blood? Someone is having diabetes, that means he will be having more glucose in the blood. If he will be having more glucose in the blood, glucose is a hyperosmolar substance. So what this glucose is going to do, it is going to drain water from the nearby cells, right? It is going to drain water and it will increase the blood volume also. It will increase the blood volume also, right? So more glucose is present in the blood, it will increase the blood volume. Second thing, nearby cells will be having what? Dehydration. So this is the dehydration which is responsible for what? This is the dehydration which is responsible for polydipsia in the patient. And if he will be having more urine, if he will be having more glucose in the that means it will absorb more water. And if more water will be coming here, what will happen? This more water will be going to the kidney, and this kidney will be filtering more water, leading to what? Polyuria. So this polyuria is due to osmotic effect. You understand why these things are happening? This is all because of this glucose present in the blood vessel. This glucose is present in the blood vessel, that means hyperglycemia, and this hyperglycemia is absorbing the water from the nearby cells, from the capillaries. What will happen? You will be having more water going to the kidney and you will be having what? Polyuria, increased urination. Increased urination will be there, and because the water is going to get away from the cells, what will happen? These cells will get dehydrated. Your brain will be having the signaling, right? You will be having dehydration, leading to what? Polydipsia. And now this glucose is not going into the cells. How you are going to make adipocytes? You will definitely have what? Weight loss will be there. You will definitely have what? Weight loss will be there. So these are going to be the these are going to be the classical symptoms of hyperglycemia. These are going to be the classical symptoms of hyperglycemia. Apart from the symptoms, if I want to talk about the diagnosis, how you are going to make the diagnosis? How you are going to make the diagnosis? Suppose if a patient is going to come to you and this patient is having all the classical symptoms. Like this patient is telling you, sir, I am having a lot of urination, I am drinking a lot. Earlier I used to eat 2 chapatis, now I am eating 5 or 6, right? These are the classical symptoms. Along with the classical symptoms, if you are doing a random blood sugar and this is coming out to be more than 200 milligram %, right? This is going to be a definitive diagnosis for what? Diabetes, right? Apart from that, you can also do what? You can also check for the values. What are the different values? We can check for the values of HbA1c. What is this HbA1c? What is this HbA1c? This is going to be your glycated or glycosylated hemoglobin. So you will be having RBCs. RBCs will be having hemoglobin, and you will be having blood in the glucose, you will be having this glucose in the blood also. right? You are having, suppose this blood vessel will be there, you are having these hemoglobin, and you are also having what, glucose here. You are also having what, glucose, and now this glucose will come and this glucose will bind here, right? Now this hemoglobin is known as what? Now this hemoglobin is known as glycated hemoglobin. Now this hemoglobin is known as glycated hemoglobin. What is the normal lifespan of a RBC? What is the normal lifespan of a RBC? The normal lifespan of a RBC is 90 to 120 days. When a glucose molecule is coming and binding with the hemoglobin, it will be having decrease in the lifespan of RBC. It will destroy the RBCs earlier also, right? And that is why we are going to understand this particular fact, that we are checking this HbA1c level, and this HbA1c level is going to tell us about what? It is going to tell us about the 90 days average sugar, 90 days average sugar of a patient, average glucose of a patient. If I want to calculate what is the average glucose of a patient in the last 90 days, I am going to do a test, and this test is known as HbA1c. This test is known as HbA1c, which is a glycated hemoglobin testing, right? Normally, what does it mean? That means if your body is having 100% of hemoglobin, just try to understand this. If your body is having 100% of hemoglobin, 100% of RBCs will be there. If 5% or less than 5% hemoglobin are glycated, that means it is normal. If your body will be having 5 or 5.6, you can write till 5.6, it is going to be normal. If your body will be having more than 5.7 to 6.4% of hemoglobin is going to be glycated, that means this patient is going to be a pre-diabetic patient. This patient is a pre-diabetic patient. If person is having more than 6.5% of HbA1c, this is definitely going to be a diabetic person, right? Suppose how we are going to calculate this. Suppose if a patient is having 7 gram percent, if the HbA1c value is coming around as 7%, if the HbA1c is coming around as 7, so what we can understand with this 7, we can multiply this 7 with 21, and this is going to be the average sugar of this particular patient in the last 90 days, right? If the value is coming more than 8, you will be multiplying it by 25, right? If value is coming like 8, so we will be calculating this, and this is going to be like 200 is the average sugar of this particular patient. So if someone is having HbA1c of 8, that means this patient is having 200 milligram of deciliter sugar per for the average sugar is going to be what? 200 mg per deciliter for the last 3 months, right? You understand this? So this is going to be the HbA1c. Apart from HbA1c, we can also do other testing like serum fructosamine testing. We can also do this. Serum fructosamine is going to tell us about the 21 days, or you can also think like that 2 to 3 weeks will be there. So if you want to check the sugar levels for 2 to 3 weeks, you can understand with the help of serum fructosamine. But this is going to be a very reliable and the best answer in your examination. You need to remember these values, right? If less than 5.6, this is going to be normal. If it is coming around at 5.7 to 6.4, this is going to be pre-diabetic. More than 6.5 is going to be diabetic. If I'm checking for fasting glucose level, if it is coming 99 or below 99, that means normal. 100 to 125 is going to be pre-diabetic patient. In those patients, we are going to advise what? We are going to advise lifestyle modification, some exercise, brisk walk. These things we will be doing. And if the value is coming more than 126, this is going to be definitely a diabetic patient, right? OGTT we can also do, where we are going to give 75 gram of glucose to the patient, and then this patient will be doing what? Then we are going to check for the level of this glucose after 2 hours. If the value is coming less than 139, this is going to be normal. 140 to 199 is going to be pre-diabetic, and if it is coming more than 200, this is going to be a diabetic patient, right? This is the cutoff values that you have to remember for the diabetes, right? This is for the hyperglycemia. What about hypoglycemia? You can also remember in hypoglycemia, if a patient is an adult patient, what is the cutoff value? And if a patient is a pediatric patient, in the adult patient, the value will be less than 55 milligram per deciliter. If someone is having 55 milligram percent, this is going to be what? This is going to be hypoglycemia. Less than 55 is hypoglycemia, but in pediatric case, we are considering it 45 milligram percent. right? So these are the values that you have to remember for the identification of this particular thing, right? Apart from that, this glucose, till the time this glucose will be present in the blood, this is going to cause what complications. What are the complications we are having? We can have microvascular complication, we can have macrovascular complications. In the brain we can have what? Macrovascular complications, like we can have stroke in the patient. In the heart, patient can have MI because of this diabetes. In the extremities, you can have diseases like diabetic foot can happen. This can lead to diabetes, can lead to shin ulcers. You can have non-healing ulcers, right? These are the macrovascular complication, big vessel complication. But the important are the microvascular complications, like you can have in the eyes. In the eyes you can have what? Retinopathy. You can have retinopathies. Here you will be having two important questions from Ophtha. They will be asking what is the most common finding that you will be having over here. So remember, most common finding is going to be the micro means small, aneurysm means dilatation will be there. So you can have micro aneurysms in the blood vessels of eye. And most specific, if they are going to ask you most specific, this is going to be what? Neovascularization means what? You will be having formation of new blood vessels in the eyes, right? And that is going to in Hindi mein you are going to call it like jala aa gaya aankh mein, right? Those people who are having what? Those people who are having diabetes, they can have this particular thing, and we can do laser therapy for that particular thing. Apart from that, we can also give drugs like you can remember one, that is what is anti-VEGF drug. These are going to be your bevacizumab, right? So these are the monoclonal antibodies that we are using in the cases of neovascularization. In kidney, it can lead to chronic renal failure. It can lead to CRF, and in fact this is one of the most important cause for CRF, right? It can also cause neuropathy, and because of this neuropathy, in fact this neuropathy is going to be the most important and most common complication. This is most common complication. This is the most common complication that we are having. This is your neuropathy that can happen, right? This neuropathy can happen. It can even precipitate your silent MI, right? So patient will not have the pain and he will be having the neuropathy, and because of that neuropathy he is not going to understand, and this can lead to silent MI in the patients, right? These are the important complications that you should be remembering. Now comes the last part. The last part is about the management, how you are going to manage this particular thing. Management for type 2 diabetes, the general management that we are advising is going to be what? For type 2 diabetes, the basic management, first line management is always going to be LSM, that is going to be lifestyle modification. We will tell the patient to control the diet. We will tell the patient to control the carbohydrate intake, right? We will encourage our patient to eat more complex carbohydrates like oats, right? And second thing we are going to tell our patient is to do exercise. We will tell our patient to do at least 150 hours of 150 minutes of exercise, not hours, right? 150 minutes of exercise in a week, right? So that is what we are going to tell our patient. Not a strenuous exercise, but at least he should walk for like 30 minutes a day, right? So that is going to be the exercise. Apart from that, we are having the drug. First drug that we want to give is going to be what? First drug is going to be the insulin. This is going to be the key. The first drug we are going to give is going to be the key, and we are having what? Different kind of insulin, like we are having rapid insulin, rapidly acting insulin. These are going to be the rapidly and short acting insulin. These are going to be your Lispro. These are going to be your Aspart. How you can remember them, you can understand this. It will be having S, it will also have the S. So this is going to be the Lispro and Aspart that we are going to use. This is what we are going to give preprandial. That means before the food, like we can give it 15 to 20 minutes before the food. Before the food we are going to give it. These are going to be good if you are going to give before the food, right? You can have short acting insulin also. You can have short acting. Short acting is going to be regular insulin. Remember, regular insulin is the only insulin that you can give IV, okay? That you can give IV. It will be working for like 30 minutes. Regular insulin you can use. Then we are having long acting insulin. long acting. These are going to be long acting insulin, are going to be glargine. Glargine, you can remember, glargine. These are going to work for like a complete day. That means if you give it like today at 8 p.m, this one will be working till tomorrow 8 p.m, so it will be having a half-life that is going to be approximately around 24 hours. This is going to be a long acting, but we are also having ultra long acting. We are also having ultra long acting, and the ultra long acting is going to be D-gludac. D-gludac. It will be working for around 42 to 45 hours. This is going to be the D-gludac, right? So these are going to be the insulin. First thing we are going to give is the key. If you do not have the key, just give the key to the patient, right? Second thing we are having is going to be the biguanides. Second drug we are having is going to be biguanides, and the drug which is going to be here is going to be your metformin. What is the example? This is going to be the metformin, fenformin, right? This metformin is the drug. This is going to be what? This is going to be the oil for our lock. Our lock is not working, type 2 diabetes mellitus. This is going to be the drug of choice for type 2 diabetes mellitus. Type 2 diabetes mellitus. Lock is not working, key is also there, lock is not working. You are going to give what? Metformin. You ask me about the mechanism. It is going to decrease what? It is going to decrease gluconeogenesis. It is going to decrease the gluconeogenesis, and second thing, it will increase the sensitivity of the receptors. It will increase the insulin sensitivity. Insulin sensitivity means what? Whatever receptor we are having at GLUT4. In fact, exercise is also going to increase the sensitivity, right? You can also that is why we are telling our patient to do exercise, right? This exercise will also increase the insulin sensitivity. Means what? Now this key will be working fine. This key will be working fine over here. If this key will be working fine, what will happen? The glucose can go inside, and that is what we are ultimately wanting. The function or the purpose is to decrease the insulin, okay, or sorry, to decrease the glucose. This is the major purpose we are having, right? There are going to be certain side effects. The most important one that you need to remember, it is going to cause lactic acidosis, and we are going to avoid this particular drug if the patient is having problems with the kidney, right? So that is going to be the second class of drugs. Third class you already know, just remember the diagram, you will easily understand. Third drug we are having is going to be sulfonylureas. This is a very hot topic. Definitely you will be getting a question from here, right? So we will be having sulfonylureas, and now you already know how this sulfonylureas are going to work. These are going to work on ATP sensitive potassium channel. ये कहाँ काम करेंगे? These are going to inhibit ATP sensitive potassium channel. If they are going to inhibit the ATP sensitive potassium channel, what will happen? Now sir, potassium will not go out, calcium will come inside, and when calcium will come inside, it will release the insulin into the blood, and now this insulin will work fine. This is what is the function of this sulfonylureas. How I told you how to remember, these are going to be G plus I drugs. Sulfonylureas are going to be G plus I drugs. We are having drugs like glimepiride, gliclazide, gliblanclamide, panclamide. So all these drugs are going to be ending with the ide. These are going to be ide, and remember the drugs which are ending with the ide, they can cause what? Hypoglycemia. They can cause what? Hypoglycemia. So because of them, if you are taking these drugs in higher doses, if you are giving these drugs in very high dose, what can happen to the patient? Patient can have hypoglycemia. And remember, hyperglycemia, nobody is going to die because of that, but hypoglycemia is going to be a very detrimental situation. You have to remember about it, right? Now next class of drugs we are having is going to be fourth one. This is going to be incretin. Total we are using 8 classes of drugs. Fourth one is going to be incretin. First one we have discussed about the insulin. Second we have discussed about the metformin, that is going to be the biguanide group of drugs. Third one we have discussed about the sulfonylureas. Now we are discussing about the incretin. Remember, this incretin has a function. The function is to increase the insulin. Simply remember this particular fact. Incretin will increase the insulin. We are having incretins like GLP-1, and remember, this GLP-1 is broken down with the help of an enzyme. This is going to be DPP-4, right? What is incretin, sir? Where is incretin? Let's try to understand incretin. So these are the incretin. These are the incretin. Can you appreciate this particular thing? It is going to regulate the release of insulin. It is going to increase the release of insulin. So this is going to be the GLP-1 receptor we are having. So if I want to increase the insulin release, can I increase this one? Because both of them are going to have the positive effect, right? So the function of this GLP-1 is to increase the insulin. So can I give something which is going to increase the GLP-1? Yes. Can we use these drugs? Yes, sir, we can use these drugs, and these are the drugs which are known as GLP-1 agonist. GLP-1 agonist, right? So what are the drugs we are having? These are going to be your GLP-1 agonist. And remember, this is going to be a peptide drug. This is going to be what? Exenatide. We are having drugs like exenatide, liraglutide, semaglutide. You can simply remember this glutide group of drugs: liraglutide, semaglutide. So all this glutide, you can simply remember glucagon like peptide. So this is going to be glucagon like peptide. You can remember like that. So glutide will be what? Peptide will be having tide. So you can simply remember now, GLP-1 are going to be the glutides. But there are going to be certain side effect of these drugs. The side effect, you can remember, they can cause pancreatitis in the patient. They can even cause cancer, medullary carcinoma of the thyroid, right? So they can cause pancreatitis. They can also cause medullary carcinoma of the thyroid. So we have to be careful in those patients who are having this particular issues. We will be very careful about it, right? Apart from that, this GLP-1 is broken down with the help of DPP-4 enzyme, right? So can I give a drug which will block this enzyme? So what will happen if I will block this enzyme? What will happen? GLP-1 will increase, and if GLP-1 will increase, what will happen? Insulin will increase, right? So we can also use a drugs. These are going to be your DPP-4 inhibitors. And these are the drugs which are known as gliptin. These are going to be gliptin. These are going to be the inhibitors, right? DPP-4 inhibitors, right? So this is going to be what we are having: drugs like sitagliptin. We are having drugs like vildagliptin. And in fact, one previous year question that they have been asking you, this is going to be linagliptin. And this linagliptin is a drug which is safe in renal failure. Even in renal failure, you need to take this drug. You can give this drug. This is going to be linagliptin को ले सकते हैं liver kidney failure में भी, right? So this is going to be the fourth class of drugs. Then we are having simple drugs. These are going to be SGLT2 inhibitor. SGLT2 pump is going to be present in this is a pump which is present in the PCT, right? And the function of this SGLT, sodium glucose like transporter, the function of this pump is to absorb 100% of glucose and 100% of amino acids. So 100% of glucose will be absorbed here. In PCT, 100% of glucose will be absorbed here, right? So this is the function of this particular pump. Now I am going to give a drug which is going to be SGLT2 inhibitor. Now what is going to happen from the kidney? Now glucose will not get absorbed. Into the body again, and this glucose will be going out into the urine, right? So this is going to cause what? This is going to cause glycosuria. Now this extra glucose will be going into the urine. My purpose is what? My purpose is to decrease the blood glucose. What is my ultimate purpose? My ultimate purpose is to decrease the blood glucose. I don't want that glucose into my blood vessel. So what I will do, I will block this pump which is reabsorbing the glucose from the kidney. So what is going to happen? Now you will be having this glucose going out into the urine. This is known as glycosuria. And if this glucose is going out into the urine, you know what can happen? This particular patient can happen UTI. This patient can have UTI because glucose will attract the bacteria and you can have UTI here, right? This is going to be the problem. In which patient I'm going to prefer this particular thing? If a patient is a patient of CHF, if the patient is having CHF, congestive heart failure is there, and along with the CHF this patient is having diabetes, I'm going to prefer this particular drug, right? What it is going to do, it is going to remove the excess of, it is going to remove the, what it is going to do, it is going to remove the excess of glucose. Let's try to understand this again. So SGLT2 pump inhibitor we are giving, it will be working on the PCT, and the function of this SGLT2 inhibitor is to remove the excess of glucose. So just think like that, if excess of glucose will be going into the urine, glucose is a hyperosmolar substance, it will produce polyuria also. Lots of fluid will be going away along with this also, right? And if this fluid is going away, what will happen? We will be having treatment of congestive heart failure. What we are having basically in congestive heart failure, we are having congestion because of the accumulation of blood, right? In the liver, in the lungs, in the lungs you can have, in the left sided heart failure you can have accumulation of fluid in the lungs. So I just want to remove the excess of fluid. Okay, so this is what we are going to use. Next class of drugs, sixth class, we are having drugs which are going to be thiodiones. These are going to be thiazolidinediones. These are going to be the drugs which are going to increase what? They are going to increase your PPAR gamma activity. They are going to increase your PPAR gamma activity. And remember, this PPAR gamma is responsible for insulin, reversal of insulin resistance. This is going to be responsible for reversal of insulin resistance. Reversal of insulin resistance. So whenever you are having insulin resistance, what we can use this particular group of drugs. These are the drugs which are going to be glitazones. What are the examples? We are having rosiglitazone, we are having pioglitazone, all glitazones will be there. We are having troglitazone, right? But these drugs are going to be treating one thing, but they are causing more damage. That is why they are not very safe, right? So what are the side effects of these drugs? Remember, rosi can cause, rosi is a cardiotoxic. Rosi is a cardiotoxic drug, right? Pioglitazone is going to be causing bladder cancer. It is going to cause bladder cancer. And this tro is associated with hepatic toxicity. Hepatic toxicity can happen, right? So these are the drugs we are using. These are going to activate your PPAR gamma activity. One antihypertensive, can anyone tell me one antihypertensive which is going to have this particular activity? This is going to be from the ARB. Just try to understand. If you remember, try to answer. Till then, the seventh class of drugs we are having, these are going to be your alpha glucosidase inhibitors. What are the examples of these drugs? These are going to be your acarbose. These are going to be your voglibose. These are going to be your miglytol, acarbose, voglibose. These are going to be the alpha glucosidase inhibitor. So what they are going to do, whatever complex carbohydrate you are eating, complex carbohydrate will be converted into glucose. So they are going to prevent the conversion of this complex carbohydrate into glucose. So now what is going to happen? If this glucose is not there, do you think this glucose can come into the blood? If this glucose cannot come into the blood, do you think this can cause hyperglycemia? No. So these are the drugs we are using: acarbose, voglibose and miglytol. But what is the side effect we can have, and where should we avoid these drugs? These drugs will be avoided in the cases of IBDs like Crohn's or ulcerative colitis. If someone is having Crohn's disease or ulcerative colitis, we are going to avoid these drugs because they are going to cause what? They are the food. They are the food. Whatever food you are not able to digest, who will be digesting that food? That food will be digested by the bacteria. You have the inbuilt dustbin, right? So in that inbuilt dustbin, you will be having what? Those bacteria in the cecum, and they will do the fermentation. And because of that, what will happen? You will be having flatulence. You will be having bloating. You will be having blotting. Sometimes if a patient is going to come to you with blotting or flatulence, or there will be for fullness, what is going to be the thing? You will be understanding this patient might be eating non-nutritive things which are non-digestible. Maybe his digestive system is having the problem, right? And because of that, what is happening? Because of that, this patient is happening flatulence and blotting. Because of why these things are happening? Gas production. Why this thing is happening? Because of fermentation. And this fermentation is going to be done with the help of bacteria. So whatever you cannot digest will go to bacteria. And if someone is having more flatulence, that means he is either eating non-nutritive things, either there is some issue with the absorption, some issue with the digestion, right? You understand this? Last, we are having the last drugs, which is going to be working here. This is going to be your amylin analog. Amylin analog, and the name of the drug is going to be your pramlintide. This is going to be the drug we are using. This is going to be pramlintide. Remember, this pramlintide is going to decrease the glucagon, and it is going to increase the insulin, and that is what we want in the cases of diabetes. We want to increase our insulin, we want to decrease our glucagon, and it is also going to decrease the gastric emptying. It is also going to decrease the gastric emptying, and this is a drug which can also be used in the type 1 diabetes mellitus. So this is going to increase insulin, and this is what we can use in the type 1 diabetes mellitus also, right? So these are all the drugs that we have discussed about it, right? What are the different drugs we have discussed? Let's try to understand it here in the diagram. So we are having first drug, that is going to be the insulin. Second drug is going to be the metformin. Third drug we are having, which is going to block this particular pump, this is going to be sulfonylureas. Fourth drug we have discussed are going to work here, that is going to be GLP agonists. These are going to be the glutide drugs, and we have discussed about the gliptins, and they are going to work here. Insulin and amylin, you can remember this amylin, insulin and C-peptide, three things will be coming together out, right? So all these things will be coming together. So this is going to be the this is going to be the drug we are working, and ultimately our purpose is what? Our purpose to remove this excess of glucose in the blood vessel. We just want to remove this excess of glucose, right? Now apart from that, we can have certain other complications, like we can have DKA, diabetic ketoacidosis, right? It is going to be seen in generally in the type 1 diabetes mellitus. In type 1 diabetes mellitus, there will be decrease in the insulin. If there is decrease in the insulin, there will be decrease in the glucose. There will be decrease in the glucose because glucose cannot go inside. If there will be decrease in the glucose, what liver will do? Liver will start the beta oxidation of fatty acids. Beta oxidation of fatty acids, and this beta oxidation will be making what? Ketone bodies. Now this ketone bodies which are formed, what are the ketone bodies we are having? We are having ketone bodies like beta hydroxybutyric acid. We are having ketone bodies like acetone, and remember this acetone is responsible for fruity smell. So now this body is going to now our body is going to make what? These ketone bodies, right? And whenever you have increase in the ketone bodies in blood, what is going to happen? You will be having ketone bodies are going to be what? Acidic, right? And you will be having metabolic acidosis because of this. You will be having metabolic acidosis because of this. And remember, whenever you have this metabolic acidosis or increase in H plus and CO2, remember CO2 and H plus are brothers for life. So whenever you have increase in H plus, you will be having increase in the CO2, and increase in H plus and CO2 will stimulate your respiratory system, and this is going to cause what? Hyperventilation. And this type of hyperventilation is known as which breathing? This is known as Kussmaul breathing. So this type of breathing pattern you will be finding, this is known as Kussmaul breathing, right? Apart from that, how you can check? You can do ABG analysis. In ABG analysis, you will be finding metabolic acidosis. You can check for urine. In urine, you can find what? Ketone bodies. You can have symptoms like this patient will be having dehydration. This is a complication of generally seen with the type 1 diabetes mellitus, right? How you are going to treat this particular situation? Treatment they are asking. First, remember, you need to give the IV fluids to the patient. First give IV fluid, NS you can give, right? Apart from that, you are going to give insulin. The only insulin that you can give IV is going to be regular insulin. That is going to be the regular insulin. You can also use what? Potassium. You need to give potassium supplementation. You can use potassium chloride, right? What are the basic side effects we are having, right? What are the clinical manifestation? What are the skin manifestation we can have? Skin manifestations that you can have. The skin manifestation, the first one in front of you, this is going to be your necrobiosis, lipodica, diabeticorum. This is the first complication that you can have. Here you will be having the ulceration on the shin. You can have shin ulcer. You can have this type of shin ulcer. This is known as necrobiosis lipodica diabeticorum. This particular infection which is associated with diabetes is very important. This is known as mucormycosis. Mucormycosis. This particular situation we are having in front of us, this is known as acanthosis nigricans. Acanthosis nigricans. And this acanthosis nigricans means that there will be thickening of stratum spinosum. And nigricans means it will be black in color. Thickening of stratum spinosum, and this is going to be black in color, and it is associated with metabolic disorders, like it is associated with diabetes mellitus, it is associated with PCOD. In fact, in PCOD, what is going to happen? In PCOD also you will be having those follicles will be arranged in the form of a string of pearl appearance. What is the basic problem there? Also the problem is insulin resistance. Now this glucose is not going inside. If this glucose is not going inside, how this follicle will get grow? Right? If this follicle will not get grow, how you will be having ovulation? There will be no ovulation, and ovulatory cycles will be there in the PCOD. So PCOD also you are going to give what? Metformin. Now because glucose will be there, cells will be there, GLUT4 will be there, everything will be there, but this glucose is not going to get inside. So same problem will be there in the cases of PCOD, leading to hirsutism and all those symptoms, right? This is a non-healing ulcer. This is a non-healing ulcer that we are having here. This is a non-healing ulcer that we are having over here. This is a non-healing ulcer, right? And this type of ulcers you are generally finding in the cases of diabetes, right? So this is pretty much everything that you need to know about diabetes, right? What are the important things that you need to understand? If you remember this particular diagram, you will be understanding all the things. Whatever drugs we have seen, all the drugs are doing what? They are removing this glucose from the blood vessel. Be it your sitagliptin, be it your I forgot to mention that. Look here. So we are having these drugs, SGLT2 inhibitor. The examples will be gliflozin. These are going to be your dapagliflozin. So you can simply remember, like, gli means glucose flows in urine. So here this particular thing, whatever drugs we are using, they are going to do what? They are going to remove the glucose in the urine. We are having drugs like dapagliflozin, empagliflozin. Very, very important, right? So all the drugs that we have discussed, let me just give you a quick recap. Insulin, basically it is going to remove all the glucose. Ultimate purpose is what? To decrease the hyperglycemia, to decrease the glucose in the blood. So we are giving insulin. Insulin is the key. It is going to take up all the glucose into the cells. Second thing, we are using biguanides. These are going to be the oil for the key, right? So this is going to do what? This is going to increase the receptor sensitivity for the insulin. Third, we have discussed about sulfonylureas. They will do what? They will increase the insulin release. They will increase the insulin. right? They will increase the insulin release. Fourth drug we have seen, incretin, they are going to increase what? They are going to increase the insulin by different methods. They are going to work on GLP. We can have GLP-1 agonist, we can have DPP-4 inhibitors, right? So this degradation is happening because of this DPP-4. So we can have this DPP-4 inhibitors, we can have this we can have this particular thing, right? Apart from that, we are having what? SGLT2 inhibitors. They are going to remove the excess of glucose into the urine. Excess of glucose will be going out into the urine. This is going to be the thing, right? Thiazolidines, these are the drugs which are going to work what? They are going to increase the receptor sensitivity so that more glucose can go inside the cells. We are having this alpha glucosidase inhibitor. It is going to stop the conversion of complex glucose into the simple glucose. This is also the same thing. We just don't want glucose, right? And amylin analog, it is going to increase what? It is going to increase the insulin. So overall function, all diabetes will revolve around two important things. First, to increase the insulin. Second, to remove the glucose. There are going to be certain complications. So wherever we will be having glucose, it is going to cause complication. It goes to eye, it goes retinopathy, it goes to your nerves, it is going to cause neuropathy, right? So these are going to be the things we are having, right? So we are going to end this with a quote, and the quote is, a river cuts through a rock not because of its power but because of its persistence. So study hard. Whatever things you are doing, just give your 100% and just keep doing things with the pace that you are doing, right? Don't leave the things, and at the last point you just need to focus. Whatever comes in your way is going to help you out. Like this diabetes, you are not just studying for the examination, but you are studying for the life, right? You are going to understand this thing once, it will be with you throughout your life because you are a doctor, right? These are my Instagram and Telegram. You can connect with me. I will be sharing the PDF in the Meduhub group, and for more classes, like this is a comprehensive class about diabetes, but in the rapid revision we are going to focus majorly on the important topics that can be asked in your examination. This is going to be like a 4-hour class where we will be discussing about the important previous year topics and previous year questions in a D&D format. Also we are going to make you understand. So this is going to be the scheme for the class. So you can join all those things on the Meduhub application, right? Stay tuned and read well. Best of luck, guys.